So benefits and some challenges of digital scanning, prep design, iOS versus traditional, tissue management, scan protocols, lab communication, troubleshooting, and some QA. So what are the benefits? Of course, there's wow factor there. So in many scenarios, of course, if you're scanning a patient on the screen and they can see what's going on there, you can show them exactly what's going on in their mouth without having to sort of pour a model up and show them physically. They can see right on the screen what's going on there, and generally that can actually help you sell cases, which is a great reason to adopt iOS. Increased treatment acceptance due to the immediate visual feedback, of course. They can see exactly what's going on and why. There's less material to stock because you're not generally having to take any impressions. If you do, it can be rare. Patients generally prefer scans to traditional impressions as well. That's much easier on the patient in most scenarios. There's also digital workflow options, meaning you can send these cases out to various labs via just straight STL scans and PLY scans. You can pretty much avoid any shipping back and forth that way, and that will save you some time. And that also means less outbound lab mail. Okay, some of the challenges here are relatively obvious, I would assume, but we'll go into those as well. So the barrier to entry can be significant in most cases. These scanners start off from somewhere around $8,000 and go all the way up to $30,000 or $40,000. So they can be fairly expensive to get into, but there's also plans to get into some of these things relatively cheaply. The learning curve and training, depending on the scanner type, can be quite advanced. Training itself is, of course, super important because if you're not trained well, then you're not going to be providing the lab with exactly what they need to succeed. And that will, of course, mean that you're not succeeding as well. There's also understanding when to choose traditional impressions versus iOS scans. In most cases these days, there's not a lot of scenarios where you have to take traditional impressions. Of course, there's going to be a few here and there when you have challenging cases, but in most scenarios, you can get away with an iOS scanner for anything from crown and bridge through implants all the way through dentures. Of course, there's also prepping differences, and we'll get into those in a minute here. But really what that means is you can't necessarily prep the same way for intraoral scans as you can for traditional impressions. And there's various reasons for that we'll get into here in a minute. What to avoid? So of course there's the obvious ones, and that's making sure that the bite is correct. And as you can see here, there's a lot of scenarios where the bites don't necessarily come through properly to the lab. You can see in the top right middle there over here, where this office took this scan, forgot to occlude them, and then when the lab got it, they were of course totally off, and we had to get a bite in there, or we could have printed those up and then hand articulated them, but that's not best case scenario. You'll see here on the top right where the margin is not necessarily clear. It's equigingival in most cases there. So it's not super easy to mark that margin. And in those scenarios, you could potentially get short margins or long margins. On the bottom here is another scenario where the bite was off and not necessarily occluded properly in the software itself, and it's also bitten through. On the left-hand side here, there's all kinds of flash for various reasons. Usually that's due to overscanning. So in most scenarios, you're going to want to get a very efficient scan, not going over many areas too often. And if you do go over areas too often, firstly, the file size is going to be quite big, which can cause some issues down the road. And you'll also get flashing like that, and also scenarios where you're potentially missing areas of the scan. This is the number one thing I go into with virtually every doctor that we have coming in, and that is you must achieve margin clarity with excellent tissue and fluid control as the mechanical displacement from the impression material is gone. What I mean by that is if you're taking traditional impressions, of course that impression material is sort of evacuating the tissue around the tooth itself and potentially making the margin look clearer than it is. And of course, if you're not doing that in iOS scans via something like packing cord or using laser or some sort of Expasil, you're essentially just going to be scanning the case exactly like you would for taking traditional impressions. And because that mechanical displacement is gone from the impression material, you'll be scanning something that is not necessarily very clear, because in a lot of those cases, because you have nothing moving the tissue away, the margin is not clear, and then again, you're going to be getting poor results from the lab. Lasers and packing cord, like I mentioned earlier there. Prep style is a big one here too, which you'll see here in a second, but really that comes down to doing chamfers and shoulders rather than knife edge margins. If you have knife edge margins, a lot of times you can just simply take that margin right down to where the tissue stops. But because there's no impression material that's evacuating that tissue or displacing it, those margins are very likely going to be too short. So getting something like chamfers and shoulders and making sure the tissue is displaced with lasers or cord will virtually eliminate that scenario. Also, direct light. You want to make sure there's no direct light overhead or anything from some sort of lamp. In those scenarios, the shine from those can actually cause problems with the scan itself. It will cause some areas on the scan to look rough or digitally distorted. So making sure there's no direct light will work in virtually every scenario with virtually every scanner. All of them will usually say to avoid direct light. And of course, keeping the teeth as dry as possible. You have to think of this as well. So when you're taking an impression with an intraoral scanner, the scanner itself does not know the difference between something like fluid and tissue or tooth. Of course, you can see those areas to some extent with a color scan, like a PLY or something like that. But in most scenarios, that in STL format, you can't tell if there's tissue or if there's fluid covering a margin. It will scan exactly where that is. So if you can keep it as dry as possible, they'll have very few scenarios where you'll have short margins due to potential fluid maintenance. Optimal prep styles, of course. Chamfers and shoulders are always number one, and I say that for various reasons. So chamfers and shoulders will be best for virtually every scenario if you're going to use intraoral scanners. And the reason why is on almost every scenario that you're going to be taking an intraoral impression or intraoral scan rather, these cases are going to go to the lab. These guys are going to be designing digitally. Those cases are going to then go to the milling center. The milling center is going to have to use milling machines, of course, to mill these out. And in a lot of scenarios, you're going to have situations where if you don't have a chamfer or a shoulder, there's going to be an issue with having margin thickness. And what I mean by that is if you have nothing behind where the margin is, where it's pushed away, like a chamfer or a shoulder, that means that the minimum thickness of the material, let's say Emax or zirconia, is going to be reliant on the actual prep itself. So if you have something like a knife edge, the very thinnest part of that is going to have to be something like 0.3 millimeters. And if you have nothing behind that, like a chamfer or a shoulder behind the margin, you can't get any thinner than that without potentially causing some microfractures. So giving some room behind the margin is going to go a long way to preventing those microfractures, and also will go a long way to making sure you have accurate margins down the line. The other part of that is softening edges of some of these crowns. So what ends up happening in a lot of scenarios as well is if you're prepping and you have sharp edges, the milling machine has to get around that sharp edge. And the only way it can get around that sharp edge is to over mill that area if a burr is not small enough to get in there. So it has to evacuate around that sharp edge, which essentially creates smaller space or more cement gap in that area than you would need. And that could actually remove room from those cases. So if you have something that's a minimal prep, let's say 1 millimeter, and that has to remove more material than necessary, you could be losing some of that room, and then you could get into a scenario where you could potentially get a fracture because you're sub 1 millimeter in those areas. So making sure you have softened edges like you can see here in this prep is going to be very beneficial. Having supragingival margins, or of course, like we talked about, having cord packed in there. As you can see here, this one's very easy to see. There's no area of this where you can't simply look at it and know where that margin is. Because it's well packed or there was laser on here, this looks like it's actually cord, and that was pulled right before scanning, which is a great strategy for that. In this scenario, you'll have very few issues with the lab actually giving you a perfect margin, because if they're screwing this up, odds are you're not using the right lab, because that's perfect. Adequate room, like we talked about a second ago. Of course, when you're prepping for these, in most scenarios, the lab is going to ask for something like 1.5 millimeters, especially for posterior cases. And a lot of these scanning systems will actually measure between the opposing and the tooth itself, so you can see exactly how much room is in there. Here's a few margin examples that are very good. This one here in the top left-hand corner, that there is no question there where the margin is. On the bottom two, those are both PLY. You can see that they're of course tissue color and tooth color, so you can see exactly where that ends. But in most scenarios, you're going to want to check between PLY and also the STL scan to make sure you can see that margin in STL format. You'll see exactly why right now. Okay, so PLY is something I think should be used as a reference point only, because you can't necessarily see where that margin is from the PLY scan. While that might look like the margin is very clear there, because that tissue and tooth, if you zoom in close on that, is not a very clear line. It can look clear from a distance, but when you zoom in on that, it's more of a graduation between tissue and tooth color. So while you can mark these margins here, what ends up happening is you can miss certain areas because you can't quite tell. And you'll see here in a second, I have a few videos to show on a lot of these processes where you can actually see what's going on there and why a lab might have problems. But as you can see here, I mismarked that margin simply because I couldn't quite tell where that ridge was. Even if you're looking around, you can't really see that very well, especially in PLY. When you look in STL format, which is the monochromatic format, you can very easily tell because of the shadows created by the software itself. Here is a sample of a very well maintained margin. You can see all the way around. There's no question as to where that margin is. Tissue's evacuated very well. In this scenario, like we talked about earlier, there's going to be almost no chance that lab's going to get this scan wrong. And while that might take a few minutes, a little longer to get that margin exposed that well, in the long run, that minute or two is going to save you a lot of headaches down the road, a lot of communication potentially between the lab and the office due to the lab potentially not knowing where that margin is and having to call and ask about it. Here's one where this one's pretty average. You'll see here in a second, I'm going to go back and forth between PLY and the STL format because you can't quite tell in this distal and lingual side here, or distal and mesial side here, where that margin might be. So referencing the PLY there on the lab side is a good way to at least understand where that margin might be. And as you can see there, a lot of times that tooth color might look gray like this, and you can't quite tell where the tooth is versus the tissue or where that margin might start. So making sure you can see it in STL format is super beneficial there. Here's one that's unfortunately very typical as well, where you can see this margin is equigingival in most scenarios here, or most areas of this case. I'll show you here as well how that might be very hard for the lab to understand once they get this up on their systems. So in a minute or so here, I will show you exactly what this looks like on the lab side, so you can see what the lab is dealing with, the tools they have to overcome this, and why they might have trouble. Okay, here's that margin marking. This is the actual lab software. This is called 3Shape. This is how the software, or how the scan rather, loads up in the software. You can see a ton of tools over here on the right-hand side to sort of figure out where things are. But because this tissue is, or rather because this margin is not easily visible, because it's not necessarily supragingival. It is in a couple areas, but in most areas it's either equigingival or potentially subgingival or covered by tissue. So we'll see here very easily, even the software can't quite tell where this margin is. When you click on top, it's taking a guess and it has no clue where that margin is. So the tools that the software has can sort of overcome that in many scenarios, but it is not going to be 100% accurate. We're going to reference the PLY here in a second. And that PLY, of course, going from underneath it may help in some scenarios as well. It's sort of like some of the model techs will do in the model room. But as you can see here, you can't quite tell where that margin is. That looks pretty good, but as soon as I flash back to PLY view, you'll see very quickly that it's not perfect. So this case sort of highlights why having a margin that's supragingival or easily exposed, which is very visible in STL format, is going to cause a lot fewer headaches down the road and will actually make it so your cases will pretty much fit without question once you get them back from the lab. I finish my crown prep margin slightly subgingivally and then use a two-core technique. I always make sure I have good isolation. Do you always recommend supragingival preps? Nope, what I mean by supragingival is not necessarily that you don't have to use anything like cord, but making that cord have your prep look like it's supragingival is kind of what I mean there. So what you're doing there is exactly right. If you're packing cord once you get everything prepped, and when you pack cord, the margin is easily visible, same exact problem there, or same exact solution rather. Excuse my ignorance, but can you please tell me what STL and PLY stand for? Sure. So it's a stereolithography scan, or rather scanned as STL. So that is your monochromatic file. PLY is just really a file type that is going to give you the color necessary to find out where the tissue versus the margin is. What if margins cannot be cleared enough? In those scenarios, really the only way to go about that is to just have the lab go as far as they can down on the prep to make sure they're getting as far as they can down gingivally. In that scenario, usually that works okay, but it's not ideal. Certainly, packing cord or using laser is going to be the best case scenario there. Although I do realize that in many scenarios, you're not going to have 100% effectiveness there. So just getting the best you can is usually pretty good there. So I wouldn't worry too much about it. I would just shoot for the best possible scans each time. Okay, here's an actual design from an intraoral scan as well, just a quad here, but you can see exactly what a tech is going to go through on a scan that is relatively average. As you can see, the person is going to flash back and forth between color and STL format. And in that scenario, you're going to probably have a very good shot at getting this one okay, because in this case here, it's not terribly bad, but it's certainly not perfect. You'll see in some areas, even if I look at this and I go, yeah, that's pretty good, I would venture to guess there's some folks that are watching this thinking, hey, that guy missed one little area there on the mesial or something, and it's not perfect. And of course, that's exactly what happens when you have somebody else interpreting a margin. So I would certainly get the best possible scenario, meaning supragingival slash margins that are evacuated by some sort of cord or laser. As you can see here, there's all kinds of tools that this lab can use to make sure that they're getting the best possible results. There's very, very little room on this one here. So what they're doing is they're selecting a button that is giving them minimum thickness. In this scenario, minimum thickness is something like 1 millimeter, but in many areas here, as you'll see here on the right, there is less than 1 millimeter there. And because of that, they're very likely going to have to call the office and say, hey, can we reduce the opposing on this? Or can we reduce the prep on this and give you a reduction coping? That's why using the tools on the software side, meaning double checking to make sure you have enough room at the end of it, is usually a good way to go about it. And I would not rely on the lab finding this out for you and potentially losing a few days. I would do this in the software itself, on the scan software rather. And in that scenario, usually you'll have a pretty good shot at getting this proper. Okay, so 3 scan strategies and the importance of following these guidelines. This is the Electra scanner, which we currently sell, and this is going to show you 3 of the most popular scan patterns. I scaled these down to about a minute each, and you'll see here that this standard scan pattern is used for many scanners. It will usually work in most scenarios, but it's not usually the one I recommend in most scenarios. You'll see the one that I show after this, it's called the infinity pattern, is one where you can hold the wand in a situation where you're not necessarily have to get in any crazy angles to make sure you can take a good scan. In this one here, you'll see that I have to sort of pivot on the anteriors to get a good scan. But in the next one, you'll see why that doesn't necessarily have to happen. This is live. This is not sped up at all. This is exactly how fast you can scan on the Electro scanner. You'll see here that I'm doing the occlusion first, then I'm going around and I'm making that pivot on the anterior, doing the buccal side in its entirety. Then I'm going to roll to the lingual side here and fill in the entire lingual side. So essentially all in one movement. But you can see I'm sort of getting in some strange angles there because of that. But you'll see here that I'm filling in all the little areas that I missed. And because of that, the scan's going to be usually good right off the bat. So the little areas that are in teal on here are the areas that AI will fill in for you. While it's not always recommended, usually it's perfectly fine in situations where you're doing something like a posterior that would be on like maybe number 2 or 3. You don't necessarily have to get a lingual interproximal on, number 13 when you're only doing number, 2 or 3 or something. So you don't necessarily have to go back and rescan those areas in. But for something like a sleep device, you want to make sure that all those interproximals are perfect because the sleep devices or something like a liner set, they need those areas to make sure that everything's moving properly. So making sure you get anything that is interproximally is perfect. Anything that's on the occlusion is perfect. In that scenario, you'll have no issues with the lab providing you with the device. Here's the infinity pattern. You'll see exactly the difference I'll go over the occlusion first. I'll come back around to the anterior, and then rather than pivoting on the anterior, I'm going to go back over to the lingual side and then repeat that pattern in reverse. You can see that I'm tilting a little bit on the incisal edges there on the anterior, and mainly that's to get as much of that tooth as possible. So when you get to this area, you can tie in easier. As you can see there, I shifted over to the lingual side. And now I'm going to go back and fill in a few little areas that I think I might have missed. Perfect. And as you can see there, that's 25 seconds. So if you're following the infinity pattern, because you don't have to shift the scanner in any weird angles, you can scan that very quickly. And you can see here there's almost no areas other than the number 10 there that'll have to rescan into the gingival. You'll see here that I simply click the button. I'll go right back into that area, fill it in, and then we're all good. And we really only have about 30 seconds of scanning total on that arch. Of course, the lingual is going to be, or rather the opposing is going to be virtually the same. And then in most scenarios, in most scanners, you're going to be taking 2 different bite scans. And those bite scans usually are going to be just the posterior, so the molars and the bicuspids, and a little bit of tissue on either side. And the exact same thing on the opposite side of the arch. The reason why you want to go through and do both scans there, if your scanner allows it, is because if you're just simply doing a quad scan for a bite on a full arch case, there's a possibility that the opposite side of that arch is going to cause some problems. So you could potentially have something like a millimeter or half millimeter out or bitten through because of that. So taking a bite scan on either side full of full arch is always recommended. Here's the inside out pattern, and this one's generally the fastest, but it can also be the most error prone. And I'll show you on the scan after this exactly how that might happen. But you can see here that I can move quite quickly, and I can get the entire thing pretty much scanned in about 20 seconds. So lingual, occlusion, and then buccal. And then I'll fill in any areas necessary. 22 seconds there, not too bad. Couple little areas there, no big deal. Of course, you can fill those in if you need to, but not necessary in this scenario. And here is the exact same scan strategy, and you can see that there's going to be an area that you get something called a double scan. And the reason why that happens is because you're hovering essentially you're hovering in outer space rather than stitching into the previously scanned area. So if you're scanning, you want to make sure that you're overlapping the previous scan area in this scan technique about 25 or 30%. And if you don't do that, it can sort of lose its place and give you something called a double scan. Now watch what happens here. As you can see in the centrals and that lateral, you can see a double scan there, two incisal tips right there. That's exactly what happens when you're not tying into the previous scan. So if you are scanning, make sure you're overlapping the previous scan by 25 or 30%. That is generally a good practice across all scanners. So of course, not all scanners are created equal. You're going to have situations where, while all scanners are clinically acceptable, and some scanners are faster or slower than others, you will find that your office is going to jibe better with one that is, let's say that maybe somebody chooses iTero and somebody else chooses Trios, and we'll consider those like PC and Mac. You're not going to convince the Mac guy that the PC is better, and you're not going to convince the PC guy that the Mac is better. So it really comes down to what operating system and what workflow you guys like the best. So I would not just simply pick a scanner and run with it, although you can certainly do that, because you're going to find that a lot of these different operating systems will work dramatically different. Some of them will have a million tools, like something like Medit. I also train on Medit, and Medit has an absolute ton of tools. And usually the offices use about a hundredth of those tools. And they're never going to get into using any of the design tools or any of those other tools that are available in that system. So it might be overkill, and you might just spend too much money on something that you don't necessarily need. So on something like Electra or something like Dexys, for example, they're relatively mild on feature sets and they're generally cheaper, but they're also very fast, and that workflow can be super quick as well. So you don't necessarily have to just simply pick the best scanner on the market because it's the best, because usually even the cheaper scanners are going to give you that same accuracy or very close to the same accuracy, and you're going to overspend simply because of the feature set. So scanners are not created equal. Doesn't mean they're bad. They're all clinically acceptable, but make sure you're not overspending for something you simply don't need. Proper scan strategies vary per system. As I just showed you, those are generally acceptable, although some systems will say not to use one over the other. Usually the scan strategy for most cases is going to be the standard scan pattern, which was just essentially developing a roadmap with the incisals, the occlusion, and then doing the lingual and the buccal side separately. But a lot of these guys will teach you in a very specific way on how to get the best results, and especially cross-arch accuracy. Another good tip is to watch the screen rather than in the mouth, because when you're watching the screen, you can see exactly where the camera is. And if you're watching the mouth, you might not necessarily see exactly where you're going. It might be hard to see that. So getting in the practice of watching the screen and placing that screen in an area sort of beyond the patient's head, you can then see that screen and move very quickly and see exactly what's going on and areas you might be overlapping or not overlapping enough, because you can see exactly what you scanned previously. So making sure you're watching the screen will make a huge difference in the end. Choosing the right system for your practice. So some of these offices or your office will be simply scanning only. Maybe you're just simply doing, crown and bridge or something very simple. You're only going to need to scan in those scenarios. You're not going to necessarily need to do anything else. So I would probably choose a system that's going to be low on feature set, but high on accuracy. Some folks are simply using these for archiving purposes. You're not going to need something that's super expensive for that, of course. Completing restorations in Office, there's lots of systems there that will do something like that. You can even use aftermarket milling machines to do something. So let's say Sirona, for example. That is an all-encompassing system that will allow you to scan, will allow you to design, and also allow you to mill in Office. So there are folks that will do this because they want something like same-day turnaround or even same-hour turnaround. But in most cases, they're not going to be doing that because you're going to spend 40, 50, $60,000 on a milling machine. And then you're going to have to stock all of the ingots. And then you're going to have some sort of oven to either sinter these cases or crystallize these cases, which just adds up, of course. And then the ROI on those are generally not very quick. So most scenarios, you're going to simply choose the scanning system that's going to give you the best results, going to allow you to send to any lab you need to send to, and then not necessarily have to worry about any of those additional features. Of course, you're just simply trying to better serve your clientele. So if you want to of course, give your clients for example, um, in most of these systems, you can scan the entire case, scan the entire mouth, show them the mouth on the screen, show them exactly what issues they have in real time, and you can even share them a video on a couple of the systems. You can actually send them an email link of the scan you took of their mouth. They can see exactly what's going on. And if you give the patients an ultra clinical look of what it looks like inside their mouth, they might find more things they want to correct than you will. So showing them that might actually get you a little more business because they say, hey, I actually want, number 7 or my lateral here to be less canted. I want it to be more in line with my arch, whatever that might be. Um, Showing them that and giving them access to their scan usually can develop additional business. Aligners, of course, every lab's going to offer, or most labs will offer aligners. iTero offers aligners. Of course, Micro and Modern offer aligners. And in those scenarios, all you're doing is scanning in. You're uploading some pictures of the patient. You're also uploading some X-rays, and that's really all you have to do. It takes maybe 3 to 5 minutes to fill in that information and then send these off. And in a matter of a couple of weeks, you're getting aligners that will cost the patients between, let's say, $3,000 and $10,000 for these aligners. And your cost, especially with Modern, is quite low. In most scenarios, you're going to be looking at sub $1,000, but super fast, super easy. And then you can also invite these patients back to get monthly checkups or bi-monthly checkups to make sure everything is going as it is. And then you can, of course, take additional scans or do checkups or cleanings in those scenarios anyway. All right, here's some of the various systems we talked about. Of course, Medit and Alletra. We sold Medit for quite a while. We still have access to that. Alletra is our own scanner. You'll see here that you have some Sirona scanners with the actual mill, the ovens. You'll see 3Shape here, as well as iTero. These are all industry standard. They're all going to give you, like I said, excellent clinical results. There's not necessarily any major difference between these other than training. So really, this comes down to making sure you have excellent training. And if anybody in the audience here has had training from Micro on something like the Alletra or the Medit scanner, we do several hours of training on these if necessary to make sure you're taking the best scans possible and giving the lab the best scans possible to cause the least problems down the road. So making sure you get great training on this is usually the difference maker. So in some systems, you're getting trained by potentially a rep that doesn't necessarily know how to scan or has no experience in this. And what they're doing is they're just simply trying to sell you something, and then they're giving you what they learned last week on how to scan these cases, and it's not always perfect. And in those situations, you're not going to be scanning perfect, and then you're going to send something into the lab, and the lab's going to give you subpar results. So make sure if you're buying any of these scanners, regardless if it's from us or not, that you request excellent training and multiple hour training, or even hands-on training if necessary, if there's a large feature set that you're buying. Something like Sirona, that can require multiple days of training. Don't let them get away with giving you quick training on these things and then saying, why aren't you getting good results? And then they're going to blame the lab. Usually it's not necessarily the lab. And I can tell this from experience. I've done probably 20,000 impressions in my career, anywhere from scanning to scanning in the lab, to designing these cases, to producing these cases. I've been involved in all of that for 2 decades. So I can tell you definitively that getting proper training on this is absolutely the difference maker. So make sure you get that. Okay, best practices review. And we're going relatively fast here because there's low questions. So certainly pop those questions in there. Even if it's outside, it can be something like manufacturing. I can get into that for you. I can get into different types of zirconia. I can get into reasons why you're choosing zirconia over Emax. Any of that stuff is on the table with me. So best practices review, of course, tissue and fluid maintenance for exposed margins is absolutely necessary in almost every situation here. You're going to get that by prepping for chamfers or shoulders in most scenarios as well. I'd say also preview STL versus PLY. So make sure you're clicking on the monochromatic versus color in that order, STL versus PLY. If you're looking at the STL format versus the PLY format, you will have a leg up and you will absolutely be giving the lab a better product and that will cause you less problems down the road if you can actually see that margin in STL format. No direct light, ambient light only. Using proper scan pass, ultra important to use proper scan pass. Don't overscan, don't go over areas too many times. Simply use those scan techniques that I showed you in this webinar here, and those will get you by in almost every situation. And lastly, like I mentioned, excellent training and support is an absolute must. Do not let anybody that sells you a scanner get away with giving you minimal support. If they give you minimal support, odds are you're going to have situations with the lab. Here's our scanner. It is the smallest and lightest scanner on the market. What you see on the screen there is quite small. It is very easy to manipulate, it's very light, and it's usually one of the easiest scanners to use on a patient because it's so small. Scan time, like I showed you, is 20 to 45 seconds per arch, and it comes as a turnkey solution with a laptop. So as soon as you get it, it is ready to go, preloaded with the software, and we do a couple 2-hour trainings or 1-hour training, depending on what you're getting into. And it also is 7 micron accuracy, so it's right in line with everything else on the market.